Mari McInerney from Croaky here, talking at the Choosing Wisely National Meeting with Professor Brendan Murphy, who's the Chief Medical Officer. You've just addressed the conference. You talked, and there's been a lot of talk that cutting costs is not a major imperative for Choosing Wisely, but you say it is, basically.
Well, I think to get a sustainable health system, the driver for clinicians is that we have to reduce waste so that we can reinvest into the exciting new drugs, new technology and things that are coming on the horizon, because government has a limited capacity to fund new things, and if we know that, as the OECD says, about 20% of our health dollar is waste, there's clear capacity for us to make some savings that actually won't be of detriment to patients, but probably will be improve care, and then reinvest that money in new technology, new drugs and new things that will provide better care. So it's not a matter of so much saving money for the bottom line of the budget, but it's about making sure that the health system overall is sustainable.
So you talked about needing a new narrative for clinicians.
Yeah.
What do we need, and what are the barriers to that?
Well, I think clinicians are not always motivated by the broader global economic imperative of the nation, because they get sometimes cynical about that, but they are very motivated about doing the best thing for their patients. So if they can see that by reducing waste, that gives the capacity of the nation to bring along new tests, new drugs and new technologies, they'll be on board very easily.
And you talked about, you had some practical examples, one of which involves your own healthcare. Can you run through those examples?
Well, I gave the example that I have some osteoarthritis in my knee, and along the process of having it evaluated, I've had some arthroscopies, which at the time we thought were helpful, but it turns out that with retrospective evidence that they really are of no benefit. So I was just explaining how with new evidence we have to change our practice and not do things that don't benefit patients.
And what were some examples that you can give?
Well, I think other examples that I've given were perhaps MRI scans also for some conditions with arthritis where there's no clear benefit for them. Sometimes people will have a colonoscopy when they have very low or no risk of having bowel cancer, and there seemed to be an unnecessary investment, whereas colonoscopy is incredibly valuable in people who have risk. So there are lots of examples of waste. There's some medications. We know that we overprescribe antibiotics, for example, the common cold or viral infections. Some patients feel that they need antibiotics, but in fact they're probably making more resistant bugs and doing them more harm than good. So there are lots of examples of waste.
Now, you talked about the MBF review, and of course that's a very contentious review in the sense that it is looking at what is a low value treatment, test, etc. You talk. Where do you see the opportunity, and do you accept that there are big risks in there too?
Yeah, I think the risks are minimised if the review is done as it is being done by clinicians. So it's been very deliberately from the outset a process that involves the relevant clinician groups looking at what's happening in their area, looking at the MBS in their particular specialty and deciding what's reasonable and appropriate, and then going out to consult. So I think potentially there are risks if bureaucrats or the government made decisions without clinician engagement, but that's not the approach of this review. So I think the risks are relatively low.
Now, that did actually get raised in a very interesting panel discussion then about the idea of perverse incentives.
Yeah.
The trouble is if you pull the wrong policy levers.
Yes, that's always the case. I mean, policy levers, you have to always think about the intended consequence and then unintended consequences, and sometimes you can't predict the unintended consequences of policy levers, and then you might have to review and adapt policy positions. So that's just a fact of life.
What would worry you with this, though, in those terms?
Look, I don't have any particular worries with the MBS review, because it's a fairly conservative process that's well valued by clinicians and well led by senior clinicians, and I think the process of consultation is such that I think we should be able to predict and prevent any perverse incentives.
What will you take away from, I know we've only just begun the discussion here today, but you've already picked up one idea. Can you say what that is and what else you
Well,
might
it was an interesting idea that one of the basic tenets of Choosing Wisely internationally is the 5 questions that patients should ask their treating clinician about the proposed management. And one of the suggestions from a consumer is that we could list them on the My Health record. Now, I don't run the My Health record, but it's something that I'd love to explore, because I think the more patients and consumers are empowered to ask questions of their treating clinicians, the more likely they are to have a mature bilateral conversation.
And something more in your field? What is there something else that you've picked up from here structurally?
Yeah, look, I think one of the things that I've picked up from today particularly is the need for a greater consumer awareness of this program, and a consumer movement to be able to have it as the norm that people have those discussions with their clinicians.
So what might that lead to from you? What can you do to aid that?
Well, I haven't got any clear ideas at the moment, but I'd like to talk to the consumer organisations about how we can perhaps support that and help that.
Okay, I thank you very much for your time.
Okay.